Hello everyone, I am Kishore Pichamuthu from CMC Velo, and in this short 10-minute session we are going to look at a few basic views of transesophageal echo. Now this objective of this session is just to familiarize you with the transesophageal echo probe and also to go through very few of the views. There are 20 standard views of transesophageal echo, but today we'll just look at 6 or 7 essential views that are needed for assessing the hemodynamics of a patient in the ICU. Now the usual indications for transesophageal echo in the ICU would be to look for a cause of shock, especially when transthoracic views are not possible because of poor windows or because the patient is prone. The other situation is when you need continuous monitoring. The advantage of the transesophageal probe is that you can leave it in place and keep looking at the image as you intervene to see how changes happen. You can also use the transesophageal probe during cardiac arrest to identify the cause of the arrest as well as to look at efficiency of CPR. And you can do this without interrupting CPR. That's advantage over transthoracic. It is also useful when you want to rule out endocarditis when that is clinically suspected and you're not able to get very clear views with a transthoracic echo. Lastly, it can also be used for procedural guidance when you want to guide the placement of ECMO catheters or IABP or transvenous pacemaker wires. So now that we've looked at what it can be used for, when is it contraindicated? Transesophageal echo cannot be done if there is an upper GI bleed, there are esophageal ulcers, varices, or gastric ulcers, or and recent bleed. Coagulopathy is also a contraindication to a transesophageal echo. So now we will look at the different parts of the transesophageal echo probe. Now the transesophageal echo probe is basically an endoscope. It's a type of endoscope with an ultrasound probe at the tip. So if you come and have a look at the the tip of this probe, you can see that on one surface there is the crystal of the ultrasound probe, and this is flat, and the beam comes out from this surface in this plane. Okay, that is the default plane, and the beam comes out like this. And you can see that this probe also has various markings along its length in centimeters, 10, 20, 30, 40, 50, 60, all the way down here, and to about 100 centimeters. Okay, and the controls of this probe, you can see here there are two wheels. There's a small wheel and a big wheel. These control the movements of the probe tip. The large wheel, if I move it clockwise, causes anti-flexion of the probe. Whereas if I do it anti-clockwise, it causes retroflexion of the probe. Okay, the smaller wheel is in charge of side-to-side movement. There you can see it's moving to the right or to the left. Now there is another set of controls here. There are buttons here that you can see. These two are buttons. Now these buttons control the angle of the ultrasound plane. Let me just show you how that works. You can see that on the ultrasound display there's a little protractor there with the angle measurement on top. Now when I press this button here, you can see that that angle changes. So for example, now I've made it 90 degrees. What that means is that the beam plane that was coming out like this has now rotated 90 degrees and is going to come out this way. This angle can be changed up to 180 degrees. Okay, that is the maximum. So basically that's a mirror image of what we would see at 0 degrees. The other button here reduces the angle and I can bring it back all the way to 0. Okay, now that we've seen the different parts of the probe, let us get familiar with the different movements that we can do with the probe to get a good image. The first obvious movement is, of course, pushing the probe in and out of the esophagus and the stomach. Okay, so sliding it in or out. The next movement is a rotational movement that we can do. The rotation, the probe can be rotated along the long axis. The wheels can then be used, of course, for anti-flexion and retroflexion and side-to-side movement. And lastly, of course, you remember these buttons which can change the angle of the ultrasound beam plane from 0 degrees to 90 degrees, 180 degrees. So all these different movements are used in combination to try and get a good ultrasound image. Okay, we will now look at how to insert the transesophageal echo probe. Now, in the ICU, most patients are going to be intubated and sedated, and so it is important, first of all, to make sure that the ET tube is well secured. Second, we may want to increase the sedation in case the patient is very awake, so that it is painless for the patient. Now, to insert this, we must take care to use a bite guard so that the patient does not bite down on this very expensive probe. To insert the transesophageal echo probe, must remember to face the surface of the probe towards the floor of the mouth. Okay, so when I'm inserting it, I put it in this way, and after making sure that the probe is adequately lubricated, I just push down, and a little bit of jaw thrust often helps to make sure that it goes into the esophagus. You may find some resistance around 15 centimeters at the upper esophageal sphincter, and once you get beyond that, it starts moving in smoothly. So if you're not able to get it with this technique, you may have to use a laryngoscope to guide it into the esophagus. Okay, now that we have inserted it, let us move to the first view. The first view is a transgastric short axis view. So we push the probe in all the way to about 45 to 50 centimeters. You can see that it's about 50 centimeters in now. The tip of the probe is in the stomach. Okay, once this has happened, we need to make sure that the probe is moved to the left. So I rotate the probe. So you can see that the probe is rotating, and I'm making sure that it's going into the left, and using the wheel here, we anti-flex the probe. Okay, so we have pushed it in to 50. We make sure that it's facing the left. We rotate the probe to the left, and then we anti-flex. Okay, we do not make any changes to the angle. And once we've done that, the view that we will get is the short axis view, and we are looking at it through the stomach and the diaphragm. In this view, the heart is being visualized through the stomach, and as you can see here, you can see that the probe is actually on the inferior surface of the heart. What you can see is a cross-sectional view of the left ventricle. That's the left ventricle there, the two papillary muscles, the septum, and you can see the small crescentric right ventricle. And this view is used to look at the size of the left ventricle and its function, to look for regional wall motion abnormalities, to look at the interventricular septal shifts and ventricular septal defects, and also to look at pericardial effusion. The next view is the transgastric long axis view. In this view, we do not have to move the esophageal probe from its current position. All we have to do is change the angle. So I'm going to use one of these angle of the beam, and I'm going to use one of these buttons and bring it up to 120 degrees. Okay, so it's 120 degrees now. So once you do this, you will now get the transgastric long axis view. In this view, the probe is still in the same place as it was for the transgastric short axis view, but it's been turned, the beam's been turned 90 degrees, and so you're getting a long axis view, and this is almost like an upside down view of what you would see in a parasternal long axis view in transthoracic echo. So you can see the left ventricle there, that's a mitral valve, that's a left atrium, that's a left ventricular outflow tract, the aortic valve and the root of the aorta and the ascending aorta. And you see a small part of the RV outflow tract. Now this view is used to look at mitral valve pathology, to look for ventricular septal defects, for LV systolic function and regional wall motion abnormalities, and to look at aortic valve as well. After the transgastric long axis view, we now move the probe out, we pull it out, till it's about 35 centimeters at the incisors. Currently, the tip of the probe is in the middle of the esophagus. We also bring the angle back to 0. It was 120 degrees, and we bring it back to 0. Now, this is a very important view. It's called the mid-esophageal 4-chamber view. And this is like the base view, in the sense that from this view, we move to different positions to get different views, and then we can come back to this. This is a very easy view, and you can see that the heart's being imaged from behind the left atrium, and this is the beam plane of the ultrasound. And this is the view that we get. We can see all 4 chambers here. The left atrium closest to the probe, the mitral valve, the left ventricle there, the right atrium, tricuspid valve, and right ventricle. And this view is used to look at chamber sizes, compare right and left ventricular chamber sizes, to look at interventricular function, septal shifts. You can use this to assess left ventricular function and regional wall motion abnormalities, to look at the mitral valve for mitral valve disease. You can also assess atrial septal defect and pericardial effusions in this view. Okay, after we've seen the mid-esophageal 4-chamber view, we can then make a small adjustment just in the angle of the beam. We take it up to 120 degrees, and this brings us to the mid-esophageal long axis view. In this mid-esophageal long axis view, you can see that the plane of the beam has changed. The location of the probe continues to be mid-esophageal. And with this view, you're looking at predominantly the left ventricle. This is almost, again, similar to the plaques view in transthoracic echo, where you're seeing the left atrium, the mitral valve, the left ventricular cavity, left ventricular outflow tract, that's the aortic valve, root of aorta and ascending aorta, and a small part of the RVOT. And this view is used to look at mitral valve disease and regurgitations, to look at left ventricular function, regional wall motion abnormalities, to measure the size of the LV outflow tract, to look at the aortic valve function as well as any aortic valvular disease and pericardial effusion as well. The next view is the mid-esophageal bicaval view. To do this, we need to rotate the probe to the right. And as you can see, I'm doing that. The probe is rotating along its long axis to the right. And after I've done that, I need to change the angle to 90 degrees. You remember we had just kept it at 120 degrees. So I can then come down to 90 degrees. Okay. And once I do this, this view that I get is the mid-esophageal bicaval view, where I can see both the IVC, SVC entering the right atrium. In the mid-esophageal bicaval view, we've rotated the probe to the right, and so you can see that the beam is now slicing through the right atrium, IVC and SVC, and so this is the kind of view that we're going to get. So if you look here, you can see that on top is the left atrium, the interatrial septum. This is the right atrium, and what we see here is the SVC, and this is the IVC. And you can see here there's a small eustachian valve between the IVC and the right atrium. And this here is a crista terminalis between the SVC and the right atrium. And this view is used when you, of course, want to look for a patent foramen ovale or an ASD. But it's also useful when you want to assess the position of central lines or pacemaker wires or ECMO cannulae. The next view after the bicaval view is a view that looks at the aorta in long axis. So from this position of the bicaval view, I then rotate the probe to the left, as you can see here. So once I've rotated the probe to the left, you will now be able to see the descending aorta in long axis. In the mid-esophageal descending aortic long axis view, we've rotated the probe to the left, and so you can see that it's slicing through the descending aorta, and because it's 90 degrees, you're going to get a long axis view in. And this is what it looks like. This is just a descending aorta. So this is useful to look at aortic pathology, to try and diagnose a dissection. And it's also useful to position an intra-aortic balloon pump catheter. after we have seen the descending aorta in the long axis. If we wish to look at it in short axis, what we need to do is just change the angle of the beam from 90 degrees that it is at currently back to 0. So I'm just doing that and it's back to 0. And once I do that, the view that I get is the mid-esophageal descending aorta short axis view. This view, the mid-esophageal descending aortic short axis view, is just a modification of the previous view in which we've just changed the angle of the beam. So we're getting a cross section of the descending aorta. And you can see that here. This is useful when you want to measure diameters of the descending aorta for various hemodynamic calculations, or you want to diagnose a dissection, and also, like in the long axis view, to look at IABP positioning. Okay, so that was all the views that we showed you, just the basic views that are necessary to make a hemodynamic assessment of a patient. There are many more views, but on a day-to-day basis in the ICU, we really don't need to know all of those. So I hope that in this short time, I've been able to make it easy for you to get a handle of the basic views of TEE. And if you've got a TEE lying around in your unit, the next time someone needs an echo, get in on it and use the knowledge that you've gained in this session and practice so that you can become an expert in TEE. Thank you.